James, thank you very much indeed. My name is Edward Timpson, and I'm the Minister for Children and Families in England. And amongst my responsibilities is for child protection. And one of the advantages of us being here in a school this morning is it demonstrates that this is something that has to be dealt with right at the earliest possible stages to ensure that children remain safe. And for too long, I think we have assumed that the systems we have in place are effective and that all the individual cases where children need protected are being dealt with. But the reason we have this summit is because, as you know, there has been a much greater understanding and focus on the crime and the abuse of female genital mutilation. And what's become clear, and the reason we're having this spotlight session, is that for each practitioner, each professional who works with children, whether it's in a school, whether it's in social services, whether it's in health services, if they work with that child individually, then often the problem doesn't come to the surface. Whereas if all those professionals work together and share information and share best practice, as well as their ability to protect and support that child, then you do get a much more effective child protection system. And what we've been doing in England is trying to make sure that the framework in place for professionals is as clear as possible as to what their responsibilities are and how they're being held accountable for the decisions that they make. And in doing so, we recognise that also schools play a critical role in giving children a sense of what is important and what they can feel that they can talk about. And without that in place, much of this remains beneath the surface. So that's why we've worked with all schools. We've written to every single school to explain what they should be doing to try and work with the issue of female genital mutilation and what action they can take should it become apparent that it is a problem. But also that the other services that work with children are given the same amount of attention to FGM as schools are themselves. And the consequence of that is that we now have a much better understanding of what a good response to FGM looks like. But for many professionals, there's still the issue of training. And one of the announcements today is around ensuring that there is good training in FGM for all those professionals who are working with children in their professional capacity. And I think that's an important step forward. But we also recognise that the traditional ways in which we engage with families doesn't always provide us with the best understanding of what needs to be done to support them. So that's why we're also looking at how we can provide a more specialised service for dealing with female genital mutilation, because the truth is that although we want to see prosecutions for FGM, if that's our sole response, then we haven't actually tackled the problem at the point where it needs to be tackled, which is at the very early stages of identification and intervention and early help. So that's the emphasis that we've put on our work here in England, but we are the first to recognise that, and the reason we have this summit is that there's much that we can learn from work that's being done elsewhere. And so I want to be able to, as Jane has said, take one practical solution to the work that we're doing today to add to the work that we're already doing, and I think that, if nothing else, is a very good reason for us all to be here today. So can I just end by thanking everybody for being here, but hope that this is a very constructive, very focused session on what we can do pragmatically to improve our response to this crime.
Thank you very much indeed, Edward, and congratulations on the work that you're doing at the Department for Education. I'm going to come now to Dr. Jaldesa to speak first. Sorry. It's the wrong way. Dr. Jaldesa, you've been working on FGMC since 1995, so many decades of experience. I think for me as a health minister, I'm particularly interested to know what the lessons are that you've gleaned from working in the health setting, what you would encourage us to do to get health workers focused on both of these issues. So if you could share some of your experience from Kenya, that would be great.
Thank you. My name is Dr. Guyo Jaldesa. I am an obstetrician gynecologist and the coordinator for Africa Coordinating Center for the Abandonment of FGM, based at the University of Nairobi. I want to share with you the role of health work professionals in ending FGM, and I want to share the experience of working among the Somalis of Kenya, some work that we did with Population Council supported by USAID. The Somali ethnic group living in Kenya has practiced the severest form of female genital cutting in fibrillation for centuries, with a prevalence of 99%. Our initial diagnostic study, found that the health system was ill-equipped to serve women who have been cut, and particularly infibulated women who are pregnant and delivering. Our diagnostic and baseline studies found that there was a strong adherence to the belief that FGM is a religious requirement, and that healthcare providers from the community who perform FGM believe that they were helping the community members by fulfilling a religious obligation. High levels of complications are likely in any community practicing severe forms of FGM, especially as seen in this population, and that healthcare providers therefore require the skills to treat and counsel these women. We use two-pronged approach to reduce the suffering caused by FGM among the Somali community living in Kenya and help the community to abandon the practice through training of health workers as agents of change and delinking the practice from Islamic religion by training religious scholars and encouraging them to talk publicly against the practice. The health workers are part of the community themselves and play an important role in decision to circumcise female members of their own families. Female health workers may be excised themselves, and in addition, and especially in urban areas, health workers are increasingly being asked to perform infibulation and re-infibulation. Many nurses are responding to this request with the justification that they can do it more safely than traditional practitioners, despite the fact that the practice is illegal and punishable. Health providers must be made aware that FGM is an abuse of girls' and women's human rights and goes against medical ethics of do no harm, and must be supported to resist requests to provide medicalized cutting. They should advise women and their husbands against re-infibulation after delivery and recommend that families do not seek FGM for their daughters. As with other health risk behaviors, health workers play an important role in any campaign addressing the issue of FGM in communities. We train 145 health workers, at least one from every functional health facility in the region, and taught on the negative consequences associated with FGM, including the evidence from WHO-led study that conducted in 6 African countries, including Kenya, that linked FGM with adverse outcomes for the mother and her newborn baby. Given that there is a strong belief in this community, even among health workers, that Islam requires FGM, all the training sessions committed some time for an Islamic scholar to speak on the lack of support for FGM in Islam. Based on the findings from this assessment and drawing from materials developed by WHO and others, a training curriculum and materials for health providers on managing FGM among pregnant and delivering women was developed by the Population Council. Our goal was to provide the health workers with advocacy tool and to educate them in identifying the different types of cutting, recognizing complications that may be associated with cutting and their management during pregnancy and delivery, understanding the socio-cultural rationale for continuing the practice and basic counseling. The curriculum has subsequently been officially adopted as a training manual by the Kenya Ministry of Health. We train religious leaders as advocates for total abandonment, not reduction in severity or medicalization of the practice, a critical and absolutely necessary initial step. We also engaged with religious scholars and educated them and the community about FGM with the aim of developing consensus that the practice is not supported by Islam, so that this message can be conveyed by the scholars to the communities. A medical expert was always present at all sessions to give a detailed explanation on the functions of the genital organs and the harm caused by FGM. This was then linked with Islamic teaching on the grace and beauty of human body and the avoidance of anything harmful. The violation of women's and girls' rights by the practice were discussed in each of the trainings, notably the right to life, good health, bodily integrity, enjoyable sexual relationship, and the right to make a choice in life. 2 female scholars opposed the practice have been identified, and one of them is now working as a resource person. Links have been established with the Somali Islamic scholars who oppose the practice, and they are being engaged as resource persons in delinking the practice from Islam. This project, in conjunction with other activities supported by other partners, notably the UNICEF and GTZ, contributed to raising public awareness about the harms associated with FGM. It will be important to continue working with religious leaders to clarify the position of Islam and to support them to feel confident in speaking out in public about their concerns. Healthcare work providers became important advocates for the abandonment of FGM during their outreach and antenatal health care services talks, but need further training, especially in the practical skills of serving women and their infants during delivery. More research is needed to generate solid evidence on which to act. We need to know more about women's and men's motivation in favor of FGM, including a desire to preserve sexual morality, acceptable sexual behavior, and femininity. And we need to know more trends in the practice within different age and social groups, and if FGC has become less common, what circumstance led to this change? With this, I say change is possible, but it requires a strong action and commitment. Thank you.
Thank you very much. I mean, there were some really important points there that I'm sure we'll return to in Q&A. I thought it very interesting that you say you've really involved scholars to make the point that there's no foundation in that case in Islam. And also I think that we might come back in Q&A to a very interesting point you made there about ensuring people don't think moving down the scales of harm on FGM is an acceptable practice. It is something that worries us about whether people might abandon type 3 but actually adopt types 1 or 2. So I think that's a very good point we might return to. Carrying on the theme of working in a health environment, I'm going to invite a member of our team at the Department of Health, our FGM advisor Astrid Fairclough, who's been working tirelessly on our programme of change for many months. I'm going to ask Astrid to talk now about what the role of a big organisation like the NHS is. Everyone knows the NHS is a large organisation, so driving change through our health system is no mean feat. But Astrid, I'd like you to just talk about some of the work that we're doing to make sure that we can drive and hardwire change throughout our health system.
Thank you very much. Good morning, ladies and gentlemen. My name's Astrid Fairclough and I'm on secondment to the Department of Health, and I'm delighted to be here today. I'm going to talk about the programme, the FGM Prevention Programme, which we've announced as part of the UK commitment this morning. Given the fantastic professionals we already have in the NHS, we know they can and will innovate to provide the services and to offer what is needed for the survivors and those we need to care and protect. But what we, therefore, are going to be focusing on is making sure that the challenge is clear and that the standards that we want the NHS to reach are set. We want to make sure that we are clear what the services that can be expected are, and that we give the support and the toolkit available to all NHS organisations so that within their own context they can make that best fit their patients, their community, their population. This is why we've embarked on the prevention programme, and we've started by looking at what is already working within our NHS. We're looking at where safeguarding is integrated in places like Bristol, although there are others of course as well. By having an integrated approach, we know that this is reaching through to families, to community groups, and driving through change in a very different way. We are also learning from the NHS specialist clinics, FGM specialist clinics, like those offering multidisciplinary offerings across London and across England, because again we think that treating the whole all the needs of the health of the patient is very important from the offset. We're also looking at where there are clinics doing really interesting using visual aids or some toolkits to help that difficult conversation, or what is seen to be a difficult conversation at the beginning, if it's not a conversation that our professionals have had very often. In this session we've already heard about a programme, and I know we'll be hearing more, where there's focus on empowering health and teachers and young people to be the agents for change. We want to develop the same approach within the NHS, But we face a slightly different situation where often the patient and the clinician come from different cultural backgrounds. So many of our clinicians have said that they're very nervous, that they don't know how to have that conversation, that it's a difficult one to do. They said that their worries have prevented them talking about FGM in the past, and we want this to be the end of that excuse. We will provide the training, provide the support, provide the information about what is going on within the community that they are caring for, so that we're empowering the health professionals to know what they're dealing with, how they can deal with it, and give them practical training on moving forward and tackling this situation. We know that health professionals have moments within a girl's life and with the family to have conversations that can lead to change. We have those opportunities, so what we're doing is looking at taking the opportunities that already exist but building upon them, making sure the conversations happen, that we tackle those difficult, what's perceived as difficult situations. Because as we've said, and as we will hear many times today, preventing one generation is protecting the future generations as well. Wherever a girl lives, we're looking at working with NHS England to make sure that this isn't just where there are high areas of prevalence. This is a countrywide standard that the NHS can and will be meeting. Within the framework of setting the expectation of where the NHS can and should get, we will also be using a lot of data work that we've been doing to find out what's really going on. And some of the announcements coming out today will be explaining that next year we'll be expanding on that, so we'll be asking more questions so that we can get a real feel within England for what has been going on and what is continuing going on. And through that we're looking to learn about patterns. So see when we're having success and there's a reduction within an area, what has been leading to that? The reason I pick up on that is because I know that Sonia has already been doing some very interesting work. That's a brief outline of what we're attempting to do, and I know that the NHS professionals in the room with us come along with us for the ride, and let's take this opportunity. So thank you very much.
Yeah, thank you, Astrid. Thank you for what you're doing. You're right. We know it's a big challenge, but there's no question that everyone is up for this, and I think that we all know that this is a real moment to seize, where we really turn a corner on it. And I think just announcing the collection of data, I said to the Home Secretary when I was a humble campaigning backbencher, and she was indeed still the Home Secretary. I said to her a few years ago, you do know that the press in Britain have got more idea of how much FGM there is out there through FOI requests to hospitals than we have in the NHS, which was just a ridiculous situation. But we're sort of taking steps to change that. We announced something earlier this year about data collection, and as Astrid said, we're looking to build on that, because we have to have data and knowledge in order that we can build the services to look after girls and women. And thank you, as Astrid said, to the health professionals in the room who are working with us. I want to turn to Saria next to just talk about the work you're doing with youth. I think we were all inspired by hearing about Saturday's Youth Summit and the energy that came from that. And we do have this amazing opportunity. We know in the case of I think virtually every harmful practice, all the evidence suggests that if you change it in one generation, it doesn't pop up again further down the line. That's why we're also optimistic we can end things in this generation. So talk to us, Sari, about what's been working in your experience in schools and in the youth programmes.
Thank you. Thank you for having me and inviting me. Good morning, everyone. My name's Saria, and I work for Forward on their youth programme, and I'm going to talk to you a bit about our schools programme and the work we deliver in schools. So I was asked to talk about systems and services, and again, like I said, would like to share some experiences, but also some lessons that we've had from our schools work. So in terms of the work we do in schools, the approach we take is within a 5 Ps framework. So we focus on things on policies, protection, provision of services, prevention and prosecution. And our work is also within the framework of the UK multi-agency guidelines on FGM, which state that education establishments should be building an open environment within schools to enable students to talk about FGM and for them to access support and guidance and counselling. So Forward very firmly believes that schools are best placed to be able to protect girls, and that's for two main reasons. First, girls students spend a substantial amount of time in schools and build up really good, trusting relationships with the staff. The second reason is that we believe that schools can play a role as a community hub, and they can help to form the norms that a community will hold. So in terms of our schools program and the work that we do, we have three main aims. Our first aim is kind of holistically looking at how do we help a school to create a safe, supportive, and open environment. The second aim is around equipping teachers to make sure they have the knowledge and the skills to better respond to FGM. And the final aim is to work with students. A lot of times when people talk about schools work, they want to jump straight to working with students, but it's thinking how do we build that safe environment first to enable those conversations to happen. So what we found through our experience when we're in schools is that girls disclose. As soon as we start talking about FGM, girls will say, this happened to me, this happened to my mum, this happened to my friend. And the work that we do in schools enables us to be able to allow girls to access support. It also enables us to work with the family, and it enables us to think about protecting younger siblings in the household. So FGM work really, for me, is all about engaging and empowering people. And when we're looking at schools work, there's three kind of key areas of people. The first is teachers, and then parents and students. So in terms of teachers' work, it's a lot around equipping them with knowledge, but also that confidence to engage in FGM dialogue. A lot of times you hear professionals feeling very anxious about having these conversations. So we do that through training, but also through resource production and provision, in terms of this is how you would have a conversation. We also do parents' engagement, and we do this in very informal, culturally sensitive and appropriate ways, a lot of times in community languages. And finally, school student work on FGM. And I think for the work that we do, that expands beyond just telling them this is what FGM is. It's about how do we actively engage young people in the campaign. Because what we know is that young people are more likely to talk to each other than they are to talk to other adults. When we ask people about where you go for support, and we say a teacher, they go, school nurse. And so what we need to do is build on this and empower young people with information and skills to be able to provide peer support and create change. So there's three key learning points from our work that I'd like to share with you to end off with. The first lesson is youth engagement. FGM happens to children and young people. This is a fact. Sometimes we forget that when we're talking about FGM. And therefore, FGM engagement should be youth-friendly, sensitive, and safe. And awareness raising should focus on challenging the social norms and beliefs that fuel the practice. It's really important that when we're talking about FGM in schools, that students understand why FGM is being discussed with them, and also to be able to place FGM in that wider context of violence against women and girls. Again, our experience has shown that when young people find out about FGM, they're always really keen to kind of get engaged, get involved in the campaign, and take action. So a lot of times, you can see they put posters up within their schools. They'll ask sometimes to have fundraising, and they'll carry that momentum within their school. Lesson 2 is whole school engagement. Everyone in a school needs to get on board. It cannot be one teacher saying, I'm going to bring FGM into my school and nobody else knows about it. All education professionals should be involved. Governors, teachers' assistants, dinner ladies, whoever young people would have a contact with and may be able to disclose. And all staff should feel really confident and sure that they know who they can speak to if they're worried or concerned about a student. What we believe is that schools play a really vital role in FGM engagement. And that's not just around safeguarding, but it's also about a support role that they play for girls and women who've undergone FGM. It's really important that as we think about ending FGM, we don't forget about girls and women who've already undergone the practice. My final lesson, lesson 3, is wider engagement. Schools must make links outwards and act as a catalyst to their wider community. Strategic schools work should expand beyond the classroom and engage a whole community. Engage health services, support services, and local government. This supports the belief that FGM is everybody's business, and we must work together to collectively challenge stigma, shift norms, develop policies, and pledge commitment and resourcing funding to help end FGM. Schools are best placed to ask the question, how are we all working together to safeguard and support the students in my school? To end, I want to leave you with the words of one of the students that we worked with. When we did an FGM session and kind of asked them to write evaluation forms, what he said was, one thing that I can do is to be aware that this happens in the UK and to write to David Cameron and ask him to do some work on it. I'm sure you'd be happy to hear about the Girls' Summit and the work we're doing. Thank you.
Thank you so much, Saria. And I'm going to turn now to Dr. Ravi Verma. And Dr. Verma, I know you've worked more widely in the area of empowerment of women and gender equality. And you've developed programs following on from Saria's comments in schools, which I know have now been taken to a number of other countries. So I wonder if you could give us some reflections, wider reflections on how we embed those ideas around gender equality and women's empowerment from schools onwards.
Thank you. Thank you very much for having me here. Very good morning. My name is Ravi Verma and I work with the International Center for Research on Women based out of New Delhi. And I'm going to talk about very briefly a program called Gender Equity Movement in School that we experimented about 7-8 years back for over 3 years in the 45 schools in Mumbai slums, doing a very rigorous RCT kind of evaluation of the program, and then followed up those kids after 5 years to see if those changes sustained and what happened in terms of forming new ideas and new norms, and what influenced those shape the new ideas. And that's the and that is where we really relied on the program like GEMS, because it drew its conceptual strength from the fact that if you are transformative in your approach, then you make a better dent into the ideas. So what did GEMS do? We experimented with a lot of innovative ideas and creative ways of engaging teachers, the parents, the communities, the children, and ideas of using GEMS diary, for example, as one way of connecting children in schools with the parents, or taking teachers into a kind of orientation programs through a very critical and reflective thinking to break their notions of hierarchical and top-down learning and teaching process. I'm not sure if you are aware, in our part of the world, teaching is a very top-down and very it's a kind of a instrument to demonstrate power, in fact, and therefore to make teachers become egalitarian and to give this information in a manner of equity and equality is something that requires a far more introspective and thinking on the part of program rather than giving just information. So using these approaches, we found that the teachers did change. And the 3 lessons that we drew from the GEMS was, one, that if teachers are transformed, they create much bigger impact on the minds of children over the period of time. 2, we found that if the children are the best change agents, they are the ones who are the role models for others. So over the period of 5 years, we found that children who had reached the age of 17, 18 and registered the idea of marriage and rather aspired for education were the ones who became role models for their own immediate reference groups. And they inspired the snowballing process of change process. And 3, we found that this GEMS program, although it was done with lots of energy and enthusiasm in the initial stages, over the period of time when it was translated into many other schools, it was easy to translate this kind of program at a scale level, because it had the elements that could provide hooks to many other structures. So we have taken, for example, GEMS outside the school and connected it to the community-based structures where we could bring children out of the schools and their parents and their community members to talk about these ideas and confront them and challenge them together, and make sure that these ideas are retained and sustained through a kind of support system that they develop. So we are very excited about GEMS. Now it's being implemented in over 30,000 schools in one of the states in India, has gone to Vietnam, has gone to Bangladesh, and is being implemented in another state, Jharkhand. And and what it is doing is it's really breaking the notions of masculinity and power and hierarchy in a manner that would have a very profound impact on many side effects, many outcomes like child marriages and different forms of violence that girls experience throughout their life and in the school system. And it engages boys and men in a manner that tells them that power is not is not by controlling someone, but in terms of respecting someone. So the whole idea of equality and power and respect has been the hallmark of the GEMS program that we are trying to inculcate in these young boys and men and the girls, and giving them the space and sense of rights. So we are very excited. I hope you share the excitement of the GEMS program, and I am sure that you can find the examples of GEMS kind of an upstream structural intervention to impact FGM as well if we do it. So thank you very much, and I'll be happy to answer any questions on this.
Thank you very much, and thank you also for reminding us about the deep attitudes that underpin all the things we're here gathered today at this summit to discuss about, as you say, the issues around power and control. I think it's really important that we always remember those first principles, because it's what these issues have in common. Our last speaker before we open up to Q&A is Sonia Aziz Malik, who is from Sudan, and she is from the Alfred University for Women, which has been working for over 30 years on around FGM in particular, and I certainly represent a number of people in my constituency in London, Sonia, from of Sudanese background. So I'm very interested to hear what the work you've been doing and how you feel. I think that the wider university sector can play a role in driving change, and we're very keen to hear from you about what's worked in your country.
Okay. Hello everybody. I'm from Sudan, as I already mentioned. Ahfad University is basically a women university. It's one of the unique universities in Africa, and one of its main vision is women empowerment. We worked in the area of, we were the first to work to raise the dialogue about FGM with partnership of with the health sector, especially an obstetrician and gynecology department at that time in the health ministry. And then after that we made what we did really is raising awareness of the communities around in Sudan regarding the issue itself. So from complete people are not speaking about it. Now it is all over speaking. This is, of course, with the help of our partners like UNICEF, UNFPA, and things that supported us. Regarding our activities, what is really important is that we integrated in our teaching syllabus all over. We are having women's studies, gender studies, reproductive rights and gender studies also. We have very specialized centers that provide this syllabus for all, as a required course for all students all over at the university. We are also having special events, annual events, monthly events that send these messages, like sports days, role plays, and live theater. And we also have special songs that we produce for the against FGM. And what is unique about Ahfad University is that we have outreach programs, and the outreach, what we call field trips. Annually, each year, the students go around to all states of the Sudan, or they enter the villages through their homes, raising the awareness, taking IC materials, and giving advice on all these issues. We are also, of course, supporting research, and this is done at the undergraduate level, the postgraduate level, and also at the PhD level. And another point which is very important, the role of our university is civic engagement. And what we mean by civic engagement is reaching communities, making projects there, developing projects there. This is, of course, by the support of our network of partners, and whether national or international, that support these activities. We do also advocacy and training through our civic education, and we target especially religious groups, health professionals, midwives, policymakers, and youth, and we also in different states of the Sudan. And also we work with the media, and this is very important. What we see about our impact, through our activities, we create CBOs and volunteers to sustain our projects, because the projects of FGM as a social change, they need to be sustained at these areas. Also in some areas where we worked, in some states where we worked, I think the impact of our projects is that now they have laws in this state, such as in South Kordofan and other states. Also some reduction of prevalence, especially in Khartoum state and Durman state. Yes. What I have really learned from all what we have done is that whether in England or in Sudan, the programs targeting FGM or early marriage must really be culturally sensitive. This is very important, and must be tied really to women's rights, to sexuality and the body. This is very important. And we also must de-link FGM from Islam. And that is why in Sudan, until now, we couldn't pass a law, a national law, criminalizing FGM. And we also need a political commitment. Luckily, you are in UK, you have this political commitment, and support of international donors for sustainability. We also need to frame our law not to consider it as a public crime, as a private crime, but as a public crime. And this lets health professionals, neighbors, family members, whenever the crime is committed, to complain. Another thing that we need is really all surveys that are undertaken worldwide. We don't have data, and the surveys undertaken are not undertaken in a holistic way. Taking, for example, Sudan, when we say that the prevalence rates in Sudan or in UK are 90%, this does not reflect the truth, because we have some states that the prevalence rates, like Khartoum state or like before southern Sudan state, where the prevalence is very low, and this makes exaggerating figures. At the end, we need, as we say, a religious fatwa, or what we call a consensus about that Islam doesn't allow all types of female genital mutilation, because by allowing the Sunnah form now, this has made midwives, doctors, medicalize the issue. Thank you.
Thank you very much. Such a strong point to end on there, and I think one that we're very aware of, and the point about data, you're so right, we need to collect that. We've got about just under 20 minutes for discussion. 15 I'm being reminded, but what I'm going to do is I'm going to ask people to indicate if they'd like to ask a question, short question ideally. Not every panel member needs to respond. I think if you want to direct it to a particular person, or the person who thinks they've got something to contribute on that point from our panel, and that way we'll try and get through quite a few. I'm going to come and give you the mic to ask your question. Say who you are, if you don't mind, and then we'll come back to the panel. So I've seen a hand there at the back. I'll come to this lady first.
Hello, I'm Samir Amin from Sudan, UNICEF consultant. My question to all panelists, because it concerns health and education, is how do you manage, or did you manage to work on the shift of social norms, which is the basic fact about the perpetuation of FGM. What I see is in education and in health, for instance, there has been a long time working on the harms of FGM or on delinking it from Islam, and it still continues, and the prevalence is still at high levels. The experience, which I'm not going to talk about it now, but the experience of the Salima campaign in Sudan is to shift the education about the goodness of being uncut, being Salima, and to shift the knowledge of instead of health hazards, to talk about the goodness of having a full genitalia, and in education on how to accept girls, cut or uncut, as part of a movement, which means accepting a new social norm of uncutting girls as the medium of education and of health. Thank you.
So, thousands of years of social norms, how do we shift them? And I'm going to ask, I think, Dr. Jaldesa, if you'd like to respond first.
Oh, sorry.
Maybe you're right, yeah.
I think, number one, I want to state clearly that in Kenya there is a good government political commitment, which is shown by the passage of a law prohibiting FGM, and also established a body that spearheads the fight against the practice. How do we manage the shift in social norms? When I was talking, I talked of something with diagnostic study, whereby before you go into any community, you need to understand what is the major reason that motivates the community into the practice. And once you have understood, and among the Somali community, the major motivation is religion, because as far as they are concerned, it is Islam religion that tells them to be performing FGM, and that without FGM, they will not go to heaven. And therefore, any government law that will be passed will be ineffective as far as they are concerned, because they will say it's an onslaught on their religion. Therefore, having understood that it is religion as the major pillar for the practice, we decided now the best person to handle is religious leaders, so that the Islamic scholars can now discuss among themselves and come to a consensus before they go to the communities. Once the community have been told that this thing has nothing to do with Islamic religion, it is purely a cultural practice, the war is already more than 50% won. They will not be clinking onto religion and therefore advocating against the practice in the name of religion. And once you have done this, and you are giving them this other evidence, scientific evidence, sometimes pictorial evidence of the harm associated with FGM, and then using the same religion now to convince them that this is actually a harmful practice and which must be stopped, it has been easy at least to get people to talk against it and shift of the position.
Dr. Jaldesa, I'm sorry, I'm going to just interrupt you because we've just been told we have to end the session a little bit earlier than expected. But I just want to just literally rapid fire across the panel. Because I'm sorry about this, everyone, but we've got a little bit less time than we hoped. I think people want us back in the plenary session a little bit earlier. But I'm just going to say, shifting the social norms, which actually is probably the single biggest question, actually. You asked the killer question there, the lady at the back. Just quick fire across the panel. Dr. Verma, best way of shifting social norms, key factor.
Well, instead of struggling to change the social norms, you must create new norms. So reward, recognize, applaud all those who are challenging these norms, those who are stepping up, support them and give them a sense of esteem and support, and that would create a new norm.
Brilliant, creating new social norms. Saria.
Probably say in the UK, and particularly with young people, framing it within the context of gender-based violence, violence against women and girls, young people can understand other issues linked to rape, linked to sexual abuse, and can then see commonalities. I also think particularly in the UK context, because it isn't as much of a social norm, it's a smaller percentage of people practicing FGM, it's thinking how do we support them when they go back to countries of origin and build up that resistance when they go back to a community where it is a social norm and it's more widely practiced.
Thank you. Sonia, shifting the social norms.
Yes, to add to what has been said already, I would also add to frame FGM within a right perspective for women. And a law must exist, a law, because the law also is a way of changing the norms and creating this. Yes.
Edward?
Well, I think the most important thing is that everything that we do mainstreams FGM and doesn't marginalise it, and so people fall back into their own communities and become very protective. And so to enable us to do that, we need strong leadership at national but also at local level. And we've had a summit here today, but what would be great would be able to see this happen in local areas, so that all the schools and all the other professionals who are engaged with FGM have a platform where they can talk about it and say that it is everybody's business, so that that whole school approach and integration of health, social and education professionals is key to make sure that we get a consistent message out there that it's safe to come forward, tell us about what's happened to you, because we're there to support you and make the difference.
Brilliant. And Astrid, finally.
I don't think there's much left. Building upon what Minister Timpson said, this is something the NHS can talk about, can deal about within our normal context of how we deal with so many different health conditions. This is something we can absolutely deal with. It's not secret, and the media have actually played a huge role in that, but we can all drive it through our daily practice.
Thank you very much. I'm sorry it's a slightly shortened session, ladies and gentlemen, but before we thank our speakers, I just want to make the point that we're all here all day, and we're all very happy if you come up, and if you had questions you didn't get the chance to ask in this session, just follow up with us during the course of the day or any other time. I think Dr. Jaldesa has some papers that you're very happy to share with other health professionals, and I think that before I ask you to just say thank you, we are, I think, then going to return to the plenary session. I think we'll all be invited to return to the main auditorium for a plenary session, and if I could ask you to thank our speakers. Sorry to be short, but thank you. Brilliant points.